Hello, everyone. Today we're going to talk about the basics of psychiatric mental health nursing, starting with nursing ethics, standards, and frameworks. As a psychiatric mental health nurse, we follow the same scope and standards of practice as all other specialties of nursing that's defined by the American Nurses Association. We also utilize the nursing process, which is the ADPI framework, and follows assessment, diagnosis, plan, intervention, and evaluation. In addition, psychiatric mental health nurses help to coordinate care for patients. They often will use health teaching and health promotion strategies. They'll use a therapeutic relationship and counseling to help their patients heal. They often utilize referrals and interdisciplinary collaboration to ensure a coordination of care. They'll use integrative therapies through biologic and pharmacological interventions. They practice milieu therapy, run educational groups, and also adhere to all the rules and regulations set forth by different regulating bodies. In addition, a psychiatric mental health nurse helps guide their patients during times of emotional stress and crisis, during any self-concept changes, if any developmental issues arise, for any physical symptoms that occur during psychological changes. They can utilize symptom management of psychiatric disorders through medication administration and non pharmacological therapies, and they always practice with ethical practice and interventions. We also utilize our nursing values and principles outlined by the Guide to the Code of Ethics for Nurses to ensure that we're practicing ethical care for our patients. While all the different nursing values apply to psychiatric nursing, the main ones that are really going to become the forefront during ethical situations are the nursing values of autonomy, veracity, and paternalism. Autonomy is allowing your patients the right to make choices for themselves. And why this is often in conflict with psychiatric nursing is because a patient may be deemed incompetent to make decisions and care for themselves. In that situation, the patient may utilize autonomy by stating that they do or don't want to take certain medications, but it may not be appropriate for their symptoms and their trajectory of care. So, as nurses, we want to find ways to really promote autonomy in our patients for those situations where the patients may not have complete authority over making their own healthcare decisions. So, for example, if a patient is on a court order for treatment, by law, they are required to take their medications. However, if a patient doesn't want to take that medication and tries to refuse, as nurses and adhering to legal standards, we have to ensure that that patient takes the medication. So, in order to promote autonomy in that specific situation, you may be able to work with the patient and say something along the lines of, I know that you don't want to take this medication, but legally we have to ensure that you're getting the treatment that you need. So, when would work best for you to take this medication? Or how would it work best for you to take this medication? Would you prefer it by mouth, in liquid form, in shot form? Did you want to take it before, after dinner, whenever applicable? Another ethical value or nursing value that is sometimes a little confusing in psychiatric nursing is the concept of veracity, which is always telling the truth. It is really important that our patients trust us and that we build a strong therapeutic relationship with our patients. However, a lot of times our patients may be disoriented to reality or they may feel disconnected from reality, especially if they're experiencing delusions or hallucinations. In those situations, a patient may have a fixed belief that is inaccurate or possibly untrue. As nurses, we never want to argue with their delusion because that could impair our patient to nurse relationship, but we still want to make sure that we're providing the patient with truth. So, for example, if you have a patient that comes up to you and says, in the middle of the night, I was kidnapped by aliens and you didn't help me. You wouldn't want to say, you weren't kidnapped by aliens, that's wrong, because then you're challenging that patient, and that is not therapeutic. It's not a conversation that's going to elicit healing or meaning with that patient. But you don't necessarily want to agree with them and say, yes, you were kidnapped by aliens, because then you're not telling the patient the truth and you're breaking that value of veracity. So, in those situations where providing the patient with true and accurate information may be compromising, we would want to focus on the patient's feelings and say something like, you must feel really uncomfortable and scared right now. How can I help you to feel more safe? Then the last nursing value that we often talk about is the concept of paternalism, or making decisions for the patient based on what you feel is best for them as a provider. A lot of times this may be ethically conflicting because a provider may not consider the patient's wants or desires when making these decisions. However, they often feel that they're making the best choice based on the patient's needs. So the example that I have for this is involuntary admission to an inpatient psychiatric facility. The patient may not want to go to that facility and the patient may not feel that that's what's best for them, but as a provider, they may make that choice to admit the patient, irregardless of their feelings, in the um, belief that they're doing what is best for that patient. So it's really important that as nurses, we make sure that we're practicing our nursing values and principles in order to provide the most ethically sound and evidence based care for our patients. There's a lot of different ways as a psychiatric mental health nurse that we can advocate for our patients and grow in our understanding and skills as psychiatric mental health nurses. Here is a list of 4 different nursing organizations that you can become a member of, and each one has different avenues for participation and knowledge growth. The most popular, or I should say most common nursing organization that you may be aware of is the American Nursing Association. Through the American Nursing Association, which admits membership to any specialty of nursing, we can advocate for psychiatric mental health nursing and psychiatric mental health care. American Psychiatric Nurses Association, or APNA, is the largest specific psychiatric-based nursing association. The mission of the Psychiatric Nursing Association is to advance psychiatric mental health nursing practice, improve mental health care for culturally diverse individuals, families, groups, and community, and to improve policy for treatment delivery. Another Psychiatric Nurses Association is the International Society of Psychiatric Mental Health Nurses. This organization, as the title indicates, is an international society, and it's divided into 4 different divisions: education and research, adult and geriatric care, child and adolescent care, and international liaison. Their mission is to unite and strengthen the presence and voice of the psychiatric mental health nurse to promote quality care for individuals and families with mental health problems. And then lastly, there's the International Nurses Society on Addiction. And the purpose of this society is to help improve evidence-based practice for the prevention, intervention, treatment, and management of addictive disorders. As a psychiatric mental health nurse, it's really important that we are advocating for our patients in better practice, especially with the lack of resources and the stigma out there in society. These are great avenues as a nurse to help fight stigma and help patients with mental illness get the care that they not only deserve, but also need. So, what is a psychiatric mental health nurse? I already talked a little bit about what they do, but it's defined more clearly as a nurse who specializes in having competency, skills, knowledge, and the ability to care for a patient with a mental illness. There's a lot of different avenues you can take as a psychiatric mental health nurse, starting with your bachelor's degree. You can work as a psychiatric mental health nurse with just your master's degree, or if you're interested in furthering your certification, you can take a certification exam and you can become a bachelor's in nursing with a psychiatric nursing certification. In order to get that certification, you have to complete so many hours of working as a psychiatric mental health nurse, and then you can sit for the exam, which shows that you have expertise and competencies specifically in treating patients with mental illness. You can also become a psychiatric nurse practitioner, which is at the master's or doctorate level, or a mental health clinical specialist. Other things that a psychiatric mental health nurse does is they help to foster health and safety for their patients. They can also assess dysfunction as well as areas of strength so that we can ensure that we're providing our patients with patient-centered care. We can help assist our patients in achieving recovery. We can help them with health promotion and health maintenance. We can often take on the role as a case manager, and that's actually a very popular field in healthcare right now is nursing case management. We can do intake evaluation and triage of patients. We're always going to be promoting self-care and a strong milieu therapy, which is caring for the environment, and we'll talk about that a little bit more soon. We're going to intervene for any psychobiological needs, including health teaching, counseling, crisis intervention, psychiatric rehabilitation, and then we can also monitor and treat withdrawal and engage in medication management. So, one strong aspect of providing care as a psychiatric mental health nurse is knowing the biopsychosocial framework. This framework, as you can see, is identifying all the ways that the individual's biological needs, psychological needs, and social needs interact and overlap with each other. Sometimes, as you can see through the overlapping of the circles, your biological needs or your biological dysfunction can lead to symptoms psychologically or socially in reverse as well. So it's really important that when we're providing care to our patients, we're identifying the different needs that the patient has and how it may affect the other realms of mental health. If we intervene on a biological basis for a biological need, we can have the potential to increase their psychological functioning as well as their social functioning. So it's really important that you have a good understanding of the biopsychosocial framework. Examples of biological needs would be things like sleep, nutrition, physical health, lab monitoring. Your psychological needs could be things like self esteem, coping skills, um, symptoms of anxiety or depression. Social needs could be your interaction with others, your ability to communicate, your environmental factors. So, all of these things are going to come into play when we're assessing our patients and making sure that we're providing them with the best care possible. So, again, some examples of the biological domain are interventions that we can do to improve exercise, sleep, nutrition, neurobiological functioning, physical health, and body chemistry. The psychological domain includes thoughts, feelings, behaviors, especially interpersonal dynamics, and then certain drives, like your drive for cognition, behavior, and emotions. Again, social domain are theories that consider the influence of social forces on the patient, family, and community while considering cultural norms. So, the tools that we use in psychiatric nursing can sometimes look a little different than other fields of nursing. While you may have situations where you need to use a blood pressure cuff or a thermometer or a stethoscope, we don't consider those the basic tools for psychiatric nursing. Rather, we consider ourselves the most important and most beneficial tool in providing proper psychiatric mental health nursing care because as ourselves, we can guide our patients, we can teach our patients, we can advocate for our patients, we can model strong behaviors and strong coping skills, we can encourage and support our patients in a way that a stethoscope or vital signs aren't able to do. As an individual, we can also use clinical reasoning, which allows us to critically think through assessments, interventions, and evaluations. We can use reflection, which is important to do both for ourselves as nurses, but also for our patients. Through reflection, we're able to enhance our self awareness. When we have enhanced self awareness, we'll know when we need to cope and how we need to cope, but it also allows us to provide non judgmental and sound care to our patients. Um, it is also really important to reflect because working in a psychiatric setting can be very emotionally taxing. And through the use of reflection, either after a shift or periodically, can help reduce rates of burnouts in nursing. One way that we recommend reflection is through meditation and journaling. It is also really important that we take times of rest and relaxation for ourselves. And during those times, we can also reflect on how we're feeling and how we can provide better care for ourselves and our patients. Another aspect of or tool of psychiatric mental health nursing is interdisciplinary care or collaboration with other health disciplines. This is going to be really important because there's a lot of gaps in the care for patients with a psychiatric disorder, especially when it pertains to fields that might not have a strong understanding or may be stigmatizing towards patients with a mental illness. So, as a nurse, as a psychiatric mental health nurse, we work a lot on coordinating care and coordinating communication between the patient psychologist, psychiatrist, um, case manager, social worker, medical provider, and any specialty providers as well. And then lastly, we utilize care plans. Care plans are going to be most effective when they're patient centered and when they reflect interdisciplinary collaboration. So, the challenges to being a strong psychiatric nurse and for providing effective psychiatric nursing care, um, first and foremost, includes lack of knowledge. We know that a lot of patient or a lot of nurses or others don't necessarily have strong understanding of psychiatric disease processes, interventions, medications, and best practice or protocols, and that can really lead to barrier in treatment. We already talked about how patients may have label avoidance, which prevents them from seeking care, but we also know that if the individuals providing care don't have a good understanding of the psychiatric disease process, they may not effectively treat that patient or provide the patient with the respect and consideration that they need. Stigma is also a strong barrier to getting effective psychiatric nursing care. Also, having poor self boundaries, poor emotional regulation, and poor self awareness on the nurse's end, and we kind of covered that already. Um, we also talked about how it can be very difficult to integrate mental health care and medical health care as well. A lot of individuals that work in the medical area kind of have the belief of, hey, we're medical, we're just going to treat the medical. You'll hear a lot of nurses say, oh, I don't do psych nursing. I don't care for psych patients, in the sense that it's not their specialty, so they don't have that level of comfort in caring for psychiatric disorders. But ultimately, you're going to be caring for patients that have psychiatric symptoms in every single healthcare setting. So essentially, every single nurse is going to be a psychiatric nurse at one point or another because they will be caring for a patient that has psychiatric needs. So the lack of integration between medical and mental knowledge and care can really be a strong barrier to nursing and to proper care for that patient. So it's really important that as nurses, we help others to see that both medical and mental health care needs are so important and that you need to treat them both together, especially because mental health care needs can lead to medical care needs, and your medical care needs can lead to mental health care needs. So it's always a good state of mind to remember you have to treat both. If your patient is admitted to the hospital with hypoglycemia and they have schizophrenia, they're not going to stop having schizophrenia just because they're on a medical floor. Technology is another factor that could be a barrier to effective psychiatric nursing, although this is a kind of a controversial one because it can also enhance um, access to effective psychiatric care nursing. The reasons that it can be difficult is because it makes it a lot harder to standardize care, and it can really lead to confidentiality issues, and it can also lead to a lot of misinformation, which can be a significant factor in inhibiting care compliance. One reason that it can be very beneficial, and as we've kind of seen over the course of the pandemic, is that it can actually increase access to mental health care, and patients that live in more rural or settings where that accessibility isn't as prevalent. Um, and then lastly, like I mentioned, we have a very heavy reliance on interdisciplinary care. It's very important and essential when it's done right. But if we don't have the proper communication, funding, and patient compliance, it really can be a barrier to transition of care and providing effective psychiatric nursing care. So, when we talk about the basis of psychiatric nursing, we want to look at a couple of different types of theoretical frameworks. The first one that I want to talk about are psychodynamic theories. And these are how your mental and emotional processes drive behaviors and relationships. This one is very heavily influenced by Freud, who created the psychoanalytic theory. And basically, this theory looks at how the conscious and unconscious mental processes work together. So there's kind of a few different parts to the psychoanalytic theory, with the first part being that your person is divided into three states of consciousness and unconsciousness. And that is your id versus your ego and your superego. So your id is your unconscious desires. It's your primitive instincts, your unstructured drives such as your sexuality and aggression. And the theory is that if our unconscious desires are not attuned or attended to, then that can result in problems with our um, with our perception, our memory, our motor control, and our ego. So your ego is your conscious awareness of your feelings, of your symptoms, of your reality. And if our id is not treated properly, and if our unconscious desires are not met, then it can impact the mental reality of our ego. The superego is our understanding, and it is a conscious process of our ethics, standards, and self criticism. Then we also have our pre-consciousness, which is unconscious material that can enter consciousness. And Freud believed that you could take your pre-consciousness from unconscious material to conscious material through things like hypnosis or dream analysis. So, psychoanalytical therapy is the process of assessing that unconscious conflict and resolving it to help reconstruct your personality and treat any psychiatric symptoms. And again, he did that through things like dream interpretation and hypnosis. Some non Freudian psychodynamic models include Alfred Adler, who believed that human motivation is based on a sense of inferiority and unreasonable desire for power and dominance. So, if somebody felt that they were inferior to another person in any realm of their life, then they would take that sense of inferiority and use it to motivate them to become better at that one thing. So, for example, if someone um, was a runner and they weren't really that as fast as some of their friends. They may feel bad about themselves and they don't like that discomfort or that feeling about being bad. So what happens is they may start to be more motivated to become a stronger runner. A lot of times, if this is not done properly, it can result in compensatory mechanisms, and the individual can actually become very neurotic about the specific issue in which they feel inferior. They may become self centered, they may overcompensate, or they may isolate themselves. Carl Jung is another non Freudian psychodynamic theorist, and he was the one that first identified the not split personalities, but that there's two different personalities out there, introversion and extroversion. And this is based on how people recharge. So, an introvert recharges and refines energy and focus through being alone, where an extrovert re-energizes and focuses by being around others. And he believed that your persona is what appears to others in contrast with who they are. So someone may be social, but it doesn't necessarily mean that they're extroverted because again, it's really who they are at their core and how they re-energize. Then we have our humanistic theories. Our humanistic theories believe that everyone has the potential of being good once they learn and accept who they are. So a lot of humanistic theories focus on who is that person and how can we enhance that self-understanding so that they can be successful in life. Carl Rogers' client-centered therapy is really a main focus of psychiatric nursing. And basically what Carl Rogers said was that as individuals, we can use empathy, which is the capacity to assume internal reference of the client and understand their perspectives, and offer unconditional positive regard, which is non judgmental interactions with that patient to help them be successful and compliant with their therapeutic interventions. And so, really, Carl Rogers' client centered therapy is the basis of what we use to understand patient centered care. Gestalt therapy by Frederick Fritz Perls is a specific type of therapy that helps with anxiety. And his belief is that anxiety is rooted in the frustration of being unable to express natural biologic or psychologic desires. So this is kind of similar to your psychoanalytic theory under the belief that if we don't address our basic needs and our basic drives, that it can lead to symptoms of mental illness or anxiety. But this is usually more focused on your awareness of those unmet needs. So, this is a form of group therapy where the individuals meet to try and understand what needs are unmet and how they can get those needs met in order to treat any anxiety that they may have. And then we have Maslow's hierarchy of needs, which is a pretty popular theory. But basically, what this hierarchy of needs states is that we need to meet our basic needs before we move to higher level of more self-aware needs. So, for example, you start off with your psychological needs. Can you breathe? Do you have food and water? Are you able to have sex, sleep, find homeostasis with your temperature and other body regulations? And are you able to excrete? Um, if the psychological needs are not met, then you're not going to be able to do things like be creative and spontaneous and all those other factors that we see with self actualization. So, a perfect example of this is I was caring for a patient one time who was a paraplegic and they had been incontinent. And I hadn't realized that they had had a episode of incontinence. So I was trying to talk to them about their feelings and kind of some of that esteem level interactions. But the patient wasn't able to focus on the conversation because they were having issues with the excretion part of their psychological needs. So that patient could not continue the conversation and could not start working on their confidence and self esteem until we had changed them and made sure that those psychological needs were met. Safety needs include security of your body, employment, resources, morality, family, health, and property. Love and belonging involves the ability to form friendships, have a strong family, as well as sexual intimacy. Esteem is based on self esteem, building confidence, building achievement, having respect for yourself as well as for and by others. And then self actualization is our highest level of needs. And that's the ability to practice our morality, our creativity, our spontaneity, our problem solving, our lack of prejudices, and our acceptance of facts. So, as psychiatric nurses, it's important that we provide those basic needs if we're expecting our patients to meet some of those higher level needs. Then we have our cognitive behavioral therapies. So, cognitive behavioral therapies look at how people learn and act. It doesn't necessarily explain why they act the way that they do, but it gives us insight on how people do learn and act. So the first one I want to talk about is the Pavlovian theory, which I think a lot of people are familiar of, especially if you've watched The Office and you know the Pavlov's dog analogy. So basically, what Pavlov did was he found that um, if he rang a bell and then provided the dogs with food, um, and did that enough times and repeated it enough that whenever he rang the bell, the dogs' mouths would salivate as if they were anticipating eating food. So we call that classical conditioning. We take an unconditioned stimuli and we pair it with a trigger so that it then becomes a conditioned stimulus. So, for example, we use this quite a bit in individuals that have autism and that have a really strong adherence to strict schedule. So if you have a patient that has a very strict schedule at home and then they have to be admitted to the hospital, they may have a lot of distress and difficulty with changes in that schedule. So if you condition them at home and maybe you play their favorite song every time you're going to do learning activities, then when they're in the hospital, we know that we can play that song to kind of condition them into, hey, we're moving into a learning activity and help that patient to feel safe as well as to kind of understand and know what to expect. Then we have Watson's behavior theory, and this is based on conditioning rather than having a mind body connection. So basically, what he said is there's two principles the principle of frequency, which means the more frequently you get a response to a stimulus, the more likely you are to either do that or to not do it. So if I work and I get paid every time I work, then I'm more likely to work so that I get paid more. So you kind of know that frequency. You often get paid when you work, so it encourages you to continue that because it's a positive reward. However, there's also the opposite if it's a negative reward. If I get burned every time I touch a fire, I'll know that that's going to be the response that happens, and I don't want that response. So it will help me avoid touching a fire. We also have the principle of recency. And basically, this means that we remember what we most recently did and the outcome. And if that outcome was positive, then we're more likely to repeat that, maybe over something that may have been more effective, but we did further back in our past. So, for example, let's say I studied every single night before an exam for 2 weeks. And I really learned that material and I studied it and I did great on the exam. The next exam, maybe I don't have as much time to study, so I make flashcards and I just memorize everything instead of really focus on understanding it. But I still get a decent enough grade. The principle of recency says that the next time that I take an exam, I'll probably just do the simple flashcards and memorization because it worked out well enough and it was more recent of what I did rather than remembering the more effective tools that I had used prior. And then we have B.F. Skinner, who came up with operant conditioning. This is kind of similar, where he stated that behaviors that are reinforced or rewarded are more likely to be repeated, and behaviors that are punished result in negative consequences are less likely to be repeated. Then we have Albert Bandura, who had two really prominent theories in the psychiatric nursing community. And the first one is the social cognitive theory. And he said that we basically learn by watching others. And this is the concept of called modeling. So we try and imitate what we see. This is really important, especially when we talk about personality disorders further on in the course, because a lot of times individuals with personality disorders or ineffective social interactions may have a hard time understanding what's an appropriate behavior socially. So, if as nurses we practice strong social behaviors, our patients will try and model that and it'll help them to build the social skills that they need. We also see the social cognitive theory as being very important in the cycle of violence. So, if someone grows up in a violent home and they see violence as the way to handle stress or conflict, that's going to be what they know. And they learn by watching others. So, then when they're in a situation of distress or conflict, they may also use violence because that's what they've seen through others. So, it's really important in understanding so that we can break that cycle of violence. Another theory that Bandura had was the self efficacy model. And this is basically an individual's sense of their ability to cope or adapt to the environment. And this model can be applied to a lot of different things, and it's the basis for a lot of evaluation tools um, in understanding what a patient feels confident in their ability to perform. Then we have our developmental theories. So, our developmental theories explain normal human growth and development over time. Erickson's psychological development is a very popular one as well. And basically, what this is he broke down different age groups and what the crisis is that people often experience during that time, as well as if they successfully cope with that crisis, which virtue they develop. So, successful completion of each crisis results in the virtue. Unsuccessful completion of each crisis will make it more difficult to develop that virtue and to progress to the next stage of the developmental growth. So, this model states that infants between the ages of 0 and 18 months have to learn trust and mistrust. If they learn that they can trust others and their provider, it allows them to develop hope. Toddlers are between 18 and 3 months, and they're working on autonomy versus shame and doubt. If they successfully feel autonomous, then they develop the virtue of will. During the preschool ages of 3 to 6 years old, they work on initiative versus guilt. If they're able to feel initiative, then they develop the virtue of purpose. Childhood between the ages of 6 and 12 is industry versus inferiority. If they're able to feel industry, then they develop the virtue of competence. In adolescence, we're looking at identity versus role confusion. If someone helps or is able to develop a strong identity, they're more likely to practice fidelity. Young adults between the ages of 19 and 40 years old are really focused on intimacy versus isolation. And if they're able to find proper intimacy, then they'll develop the virtue of love. Middle adulthood between the ages of 40 and 65 works on generativity versus stagnation. So this is when a lot of people you'll hear them say that someone's in a midlife crisis. That's because they're working on finding generativity. They're trying to reassess their life and say, "Hey, where am I important? Where am I producing something? Where am I needed?" And if they meet generativity, then they develop the virtue of care. And then finally, seniors are greater than the age of 65, and they're working on ego integrity versus despair. And if they are able to find that point of ego integrity, then they develop the virtue of wisdom. And this model is really important because it helps us to better understand what the needs are for our patients at different age levels. Then we have Piaget's theory of cognitive development. And this defines cognitive growth as organized in structures that become more differentiated over time. And the basis of the theory of cognitive development is that differentiating our organized structures allows us to develop knowledge. So, the different stages of this is the sensory-motor stage, and this is from birth to 2 years old. This is when the individual identifies object permanence, as well as the ability to control objects and act intentionally. Pre-operational is between the ages of 2 and 7, and this is when they begin to use language and develop egocentric thinking. So, this means that they can just understand what they're thinking, but they don't necessarily have the ability to see others' viewpoints. They're also able to classify objects by a single feature. Our concrete operational phase is between the ages of 7 and 11. At this point, they've developed some logical thinking. They can also recognize the conservation of numbers, mass, and weight, and they start to classify objects based on more features than one. Formal operations is 11 years and older, and this is when they develop both logical as well as abstract thinking. They can focus on hypothetical thought, critical thinking, and they can also form hypotheses and test their own hypothesis to determine their level of knowledge. Then we have our social theories. Social theories are going to be really important in understanding how to best support a patient and how to best strengthen their support systems. So, in our social theories, we have some different terms. The first one being family dynamics. And this is patterned interpersonal and social interactions that occur within a family structure over time. So, you can have an open system, meaning that changes within one person affects the whole system, or you can have a closed system, which often does not describe family dynamics, but rather a lack of family dynamics, meaning that if something happens to one person, it's not going to affect others. But because we want to promote strong family dynamics, we have to have an understanding of this open system. So, for example, if somebody is working and they have a bunch of kids at home and stuff and they lose their job, that doesn't just affect that person, but it affects their children, it affects their spouse. So we want to make sure that we're aware of that and how the patient's experiences and the patient's symptoms may also be affecting others. Social distance is another term, which is the degree to which the values of the formal organization and primary group members differ. So, this can be decreased through identifying communication barriers, and it can help promote social connectedness if we can identify those barriers and help people recognize their um, similarities. Then we have our two different support systems. Your formal support systems are organizations that provide care to an individual. And then you have your informal support systems, which is family, friends, and neighbors that provide care to an individual. As a nurse, it's really, really important that we have a good understanding of formal support systems that we can refer our patients to, but also how we can help coordinate collaboration between the informal and the formal support systems. Then we have our psychiatric nursing theorist. And the one that I really want to talk about is Hildegard Peplau. So, Hildegard Peplau is kind of known as the mother of psychiatric nursing because she's the first one that coined the use of therapeutic use of self, which I talked about earlier today, and how, as nurses, ourselves can be the most important factor and the most important tool in providing effective psychiatric nursing care. And the reason for that is because she believed that through limiting self disclosure and using proper communication techniques, we can encourage the patient to focus on themselves. We can help them realize the root of their problems, and we can encourage them to cope and address those problems in a way that they feel supported, confident, and cared for. One key aspect to using therapeutic use of self is the use of empathetic linkages. So, we defined empathy earlier, where it's the ability to understand a patient's perspective on what they're going through. And if we understand a patient's perspective, then we can better provide that patient centered care. The last theory that I want to talk about is milieu therapy. So, milieu therapy is essentially caring for the environment and ensuring that we are creating a healing environment for our patients. The three questions that I like to ask when providing proper milieu therapy is one, is the environment safe? We know based on Maslow's hierarchy of needs that if someone is not in a safe environment, they're not going to be able to start working on things like coping skills and that higher needs um, level. So we want to make sure that we're looking for any safety hazards, one, to keep our patients safe, but also so that they can focus on their higher level needs. Then we want to look at, is the environment pleasing with appropriate resources? We know that when individuals are in a more aesthetically pleasing environment, they're more motivated and they're better focused. So, if we have a patient that's in an environment that's going to encourage their creativity and their focus and their motivation, we want to provide that with them, provide that for them. We also know that if patients don't have the resources that they need, they're not going to be able to attend to their needs. So, lastly, we want to look at, does the environment support appropriate social interactions? Um, and this again is looking at both those formal and informal support systems. Some barriers to effective and appropriate social interactions on the inpatient unit could be things like if you have patients that are forming a relationship with each other. While we want to support connection and relationships, we also want our patients to be able to focus on themselves and their healing. And if they're in an inpatient facility and they're forming deep romantic relationships with others, they may neglect the ability to focus on internal healing themselves. Other barriers to strong social interactions in an inpatient facility may be things like conflict. If patients aren't getting along, and they're arguing, that can be tense for both the patients, but it can also upset other patients that are within that environment. So we may need to do specific interventions like separate those patients or use conflict management to ensure that we're providing a strong environment that allows for appropriate social interactions. So now we're going to look at the biological foundation of psychiatric nursing. A lot of this may be review from anatomy and physiology, but it's looking a lot at what our brain does, how it works, and how that impacts mental illness. So here's a picture of the different brain systems that we're kind of going to talk about today. You have your brain stem, which kind of does your basic human regulation. And then you have your cerebrum, which is kind of that higher level thinking and what allows us to be critical thinkers. So when we look at the brain system, we look at the central nervous system versus the peripheral nervous system. Our central nervous system is the brain stem, the brain, and the spinal cord, where the peripheral nervous system is all the neurons that connect our central nervous system to our muscles, organs, and other body symptoms. So essentially, your central nervous system is what does all the thinking and initiates all the actions, and the peripheral nervous system is what transports that communication to the body to ensure that the body's doing what it needs to do. So the CNS is the working center for the neural system, where the peripheral neural system is your communication route. So your cerebrum is composed of your cortex. It can also be divided into your left and right hemisphere, or it could be divided into lobes, which is your frontal lobe, your parietal lobe, your temporal lobe, and your occipital lobe. Your cortex, like I mentioned, is possibly divided between the right and left hemisphere. The right hemisphere controls the activities of the left side of the body, and it's our main center for understanding nonverbal communication, spatial orientation and recognition, annotation of speech, facial recognition, expression and emotion, and nonverbal learning. Whereas the left side controls activities on the right side of the body. It is very much involved in verbal learning and memory, as well as verbal language function, receptive and expressive speech, temporal ordering and sequencing, and understanding numerics and symbols. So your right-brained individuals still use their left brain. They're still able to kind of combine the function of the two, but people that are right brain dominant are usually defined as being more creative, where individuals that are left brain dominant are usually more logical. The way that these two hemispheres connect and communicate with each other is through the corpus callosum. The corpus callosum, like I said, allows that communication. But in individuals with severe epileptic seizures, they have found that severing the corpus callosum can treat those seizures. So when this happens, we develop what's called split brain phenomenon. And that's when the communication between the right and left are no longer present. So they both function effectively, but there's not that connection there. So someone may be raising their right hand, but they're not aware of it because of that disconnect between the two brain hemispheres. So now the different lobes of the brain. Our frontal lobe is our primary motor control area. It's also where our personality develops, where our working memory and executive functioning occurs, and it's where we have Broca's area. So Broca's area is our expressive speech, or our ability to say what we intend to say. So damage to the frontal lobe can result in expressive aphasia. It can also um, cause different levels of intellectual thinking and awareness, as well as personality changes. So I'm sure that you guys have probably heard the story of Phineas Gage. So Phineas Gage was a worker that had a specific personality, and then due to an injury at work, a rod had gone through his frontal lobe. After the rod had gone through his frontal lobe, he had a completely different personality. Damage to the frontal lobe is often associated with schizophrenia, ADHD, and dementia. So think about it. When you know that the frontal lobe is what helps our working memory and our executive functioning, we know that patients with dementia often have an ability to form new memories, or they have difficulty with that executive functioning. So if you understand the different lobes of the brain, it can help you to understand the symptoms that patients have um, with different psychiatric disorders. Your parietal lobe is your sensory input interpretation center, and it helps to understand things like touch, calculations, writing and drawing, and spatial direction. Your temporal lobe is the main center for your auditory and olfactory sensation. We also have Wernicke's area, which is the area that allows for receptive speech, so the ability to understand what others are saying. So if you have damage to your temporal lobe, you may have receptive aphasia, where you're unable to understand others, but you may still be able to speak what you feel you need to speak. And the temporal lobe also helps regulate mood and emotion. So a lot of times people will say things like perfume, smelling certain perfume can bring you back to certain memories. That's because both the olfactory sensation and mood and emotion is connected together. And then lastly, we have our occipital lobe, which is our visual control. Damage to the occipital lobe can cause cortical blindness. Similar to the corpus callosum, all four lobes can communicate and interact with each other. This ability to interact with each other is called the association cortex. So this helps to control association areas. Then we have our subcortical structures, and this is our white matter and our gray matter. So, white matter is involved with regulating mood and behaviors. If someone has a mood disorder or maybe behavior disorders, we can provide medications that are going to target that white matter. Our basal ganglia, also called our gray matter, is what controls our motor functioning, especially with repetitive behaviors. Um, so a lot of psychiatric medications that you'll learn about, it may really focus on treating the white matter, but because the white matter and the basal ganglia sometimes interact, it can also cause poor motor functioning or motor side effects of the medications. Then we have our limbic system. So our limbic system primarily controls emotions, needs, drives, and instinct. And the limbic system is often dysfunctional in a lot of different psychiatric illnesses. So, for example, borderline personality disorder, which you won't learn about for a while, but it's a disorder where the individual has poor emotional regulation. They often overreact to situations and they really feel emotions very deeply and out of proportion to what's going on. But we also know that their limbic system is a little bit slower than what we would expect to see. So that is part of the contributing factor to why they have such poor emotional regulation. Our brainstem, actually, let me go back. Um, Sorry, I lost my train of thought. Um, our hippocampus is also part of our limbic system, and it's present in the brainstem. And the hippocampus is important in storing information, and it helps us to attach emotions to memories. Damage to the hippocampus can also result in Alzheimer's. This is very similar to other parts of the brain, but again, that's because on a whole, our brain interacts with each other to form its proper functioning. Other structures in the limbic system that you may hear is the thalamus and the hypothalamus, the amygdala, and the limbic midbrain nuclei. So your thalamus and hypothalamus help to control your sensory input as well as control your regulatory cycles and patterns. Your amygdala helps to modulate aggression and sexuality as well as understand our sense of smell. And our limbic midbrain nuclei is our pleasure reward center. So it's what releases that dopamine and serotonin and the chemicals of pleasure that lead us to repeat behaviors that cause that chemical release. So I know a lot of this is maybe confusing, but as we go through the different disorders and we talk about the development of these disorders, we'll refer back to these different systems and understand how it leads to the symptoms that a patient experiences. So our brainstem helps to mediate symptoms of emotional dysfunction, and it's also the source of our neurochemicals. It helps to regulate our hemostasis and our regulatory functioning. Then we also have our cerebellum. So our cerebellum is a brain structure that controls movement and balance. And this is affected by a lot of psychotropic medications. So a lot of patients that are being treated for psychiatric disorders will have balance issues and they could be a high fall risk. Then we have our nerves and our nerve transmission. So our autonomic nervous system, as I mentioned, is our peripheral nervous system, and it has two different pathways. Efferent pathways, which moves away from the brain, so it's the brain signal to our body parts, or afferent pathways, which is our body parts moving the signal up to our brain. And through the nervous system, we have two different responses. We have our sympathetic response, which is driven by the release of norepinephrine, and that's our flight or fight response. So it allows us to have an increased heart rate, muscle contractility, pupil dilation, sweat secretion, while relaxing the lungs, the GI tract, and the bladder. And the purpose of your sympathetic response is that it's a response to any time you feel threatened. So evolutionarily, when individuals hunted for their own food and were out in the wild a lot more, they may see a bear or an animal that could harm them. That caused the activation of their sympathetic response, which would give them the increased heart rate and contractility and pupil dilation to see better in the dark, to run away, while relaxing their GI tract and their bladder so that they're not being distracted by their needs of hunger and things like that. And that's a lot of times too how when someone is scared a lot, they may actually have a moment of incontinence. Your parasympathetic response is driven by acetylcholine and it causes the opposite. So it's the relaxation state. It causes a decrease in heart rate and muscle contractility. It constricts the pupils while increase in GI motility, bladder contraction, and bronchial constriction. And these are important to understand because in disorders like anxiety, there's an abnormal functioning of the sympathetic and parasympathetic responses. In order to best understand nerve transmission, we want to look at the neuron. So a neuron is a cell that receives, organizes, and transmits information throughout the body. We know that we have neuroplasticity, which is our ability to form new connections between our neurons and to have the neurons grow and flourish in areas of our brain that we use more frequently. So if you look at the neuron, there's the different structures. The dendrites receive a signal, which goes through the nucleus or the cell body, where that signal is processed. Once the signal is processed, it's sent down the axon to the axon endings. The axon endings then release that electrical chemical into the synaptic cleft. And the synaptic cleft is where the electrical symbol becomes a chemical one. And that chemical symbol or that chemical signal can then be picked up by the receptors on the dendrites and converted back into an electrical symbol. And that's called an impulse. We know that our dendrites have different receptors which accept the different neurotransmitters to send a certain message. The receptors are often specific so that other neurotransmitters don't necessarily activate certain receptors. The main thing that I want you guys to know about this is the basis for a lot of medications. We can identify which signals are not being communicated effectively through the brain, and then we can figure out what neurotransmitters and what function that occurs in, and we can provide medications that go to that region of the brain and allow either release or inhibition of those neurotransmitters to control the messages that are sent in the brain. So now onto the neurotransmitters. There are hundreds and hundreds and hundreds of neurotransmitters. There's different types of the same neurotransmitter, but the main ones that we're going to talk about as they pertain to psychiatric nursing are acetylcholine or ACH, dopamine, norepinephrine, serotonin, histamine, GABA, and other ones that you may also hear about are like glutamate, neuropeptides, melatonin, and those are often contributing to pain control and experience, neuropathy, insomnia, and side effects of medications. So acetylcholine is an excitatory neurotransmitter, and it contributes to memory, wakefulness, attention, and maintaining emotional states. So acetylcholine loss can result in Alzheimer's or Down syndrome. And we also find that sometimes having too much ACH can lead to things like ADHD. Dopamine is another excitatory neurotransmitter, and it's involved in cognition, motor function, neuroendocrine function, mood states, and regulating action, motivation, and attention. This is often our rewards pathway neurotransmitter. We do know that decreased levels of dopamine can result in symptoms with Parkinsonism, and increased levels of dopamine can result in symptoms seen in schizophrenia. Norepinephrine is an excitatory neurotransmitter as well, and it's involved in mood states, the sleep-wake cycle, reinforcement and learning, endocrine function, and as we already talked about, fight or flight. So decreased levels of norepinephrine can lead to depression, where increased levels can lead to mania and anxiety. Serotonin is another excitatory or neurotransmitter, and it's seen in regulating emotions, cognition, sensory perception, sleep, appetite, relaxation, hormone secretion, thermal regulation, and cardiac regulation. So individuals that have too much serotonin can experience mania or migraines, and individuals that have decreased levels of serotonin can experience depression and insomnia. Then we have histamine. So histamine is a neurotransmitter that is involved in autonomic and neuroendocrine regulation. So histamine doesn't necessarily contribute to any psychiatric disorders, but we know that it is blocked by a lot of psychiatric medications. It is helpful in treating a lot of side effects of psychiatric medications. We do know that when we provide someone with an antihistamine, so we're decreasing their level of histamine, we see things like sedation, weight gain, and hypotension. GABA is an inhibiting neurotransmitter that's involved in reflexes, and it also causes dysregulation that leads to anxiety and seizure disorders. Then we have glutamate, which is mostly important in learning and memory. Increased levels of glutamate can lead to withdrawal symptoms, ischemia, hypoxia, hypoglycemia, and hepatic failure. And glutamate levels are really important when we look at neurodegenerative disorders like Huntington's, Parkinson's, Alzheimer's, ALS, and AIDS-related dementia. We also know that decreased levels of glutamate can contribute to some of the symptoms in schizophrenia. So now the biological basis of mental disorders. Why do mental disorders happen, and what biological dysfunction can lead to it? So first and foremost, we want to look at the genetics. Genetics plays a big role in the development of mental illness, although we don't necessarily always know why. So when we look at genetics, you have your genetic code, which is having the gene for that trait, but we call it a phenotype when that trait is expressed. So someone may have the gene for bipolar disorder, or they may have the gene for schizophrenia, but if the gene hasn't been activated and they're not showing the symptoms of that, they might not necessarily be diagnosed with that disorder. The way that we try and understand the role that genetics plays in mental illness is through family studies, twin studies, and adoption studies. There's a lot of work going on right now trying to identify different genes that affect things like anxiety or depression, as well as how our body responds to certain medications. So you'll learn a lot about that as the course progresses as well. Psychoneuroimmunology is the study of the relationship between the immune system, the nervous system, the endocrine system, and an individual's thoughts, behaviors, and feelings. So think of it as this: a lot of times with hypothyroidism, we know that we have decreased levels of the proper thyroid hormones. That can lead to a lot of symptoms that look a lot like depression. So it's that interaction between the endocrine system and the nervous system that impacts our thoughts and feelings. We know that individuals that are under stress have compromised immune systems, and they're also more likely to develop diseases. This makes sense when you think about medical diseases, but we also know that they're at increased risk for developing mental diseases as well. Um, so sometimes you may see certain things like when someone's psychotic, they may have a higher white blood cell count. Then we have chronobiology, and this is looking at the dysfunction of biological rhythms and how that can contribute to psychiatric illnesses. So, for example, if someone is not getting enough sleep, they may have increased symptoms of mania or increased symptoms of depression. So, this is looking at how and why our different regulatory cycles lead to certain symptoms. Some diagnostic tools that we can use for studying psychiatric disorders include our biological markers. So these are diagnostic test findings that are only present during symptoms of a psychiatric disorder. We can also measure our different neurotransmitter levels. And then a lot of times we'll want to look at their basic metabolic studies, their CBC, for looking for any of those medical reasons for psychiatric symptoms. A lot of times, the medications that we provide have narrow therapeutic indexes, and so we often will do blood work to measure the levels of medications in the blood. We especially do this with medications like lithium and Depakote, which you'll learn about next week. Certain medications can also cause damage to our body's ability to form new blood cells. So, if someone is taking clozaril, we would want to study their CBC. There's also different procedures that we can do to assess for the presence of any psychiatric disorders, one such being the EEG. So, the EEG measures electrical activity in the cortex and it can identify things like seizures, head injuries, tumors, or epilepsy. And basically, what it does is it looks at those brain waves to determine if any of those dysfunctions are there. But a lot of psychiatric medications can also change those brain waves. So, for example, benzodiazepines, which are used to treat anxiety or alcohol withdrawal, can increase beta waves. Lithium can increase theta waves. And not that I expect you to know what those are, but I just want you to know that certain medications that are used to treat psychiatric disorders can cause abnormalities in an EEG. Other imaging that we can do to assess for any dysfunctioning that may lead to psychiatric symptoms are your MRIs, your PET scans, and that's all that I want to talk about.